Good morning, everyone. I'm happy to be sharing our findings on a study that we did that was looking at 6-monthly, multi-month dispensing of antiretroviral therapy, and we were looking at acceptability, feasibility, and effectiveness of rolling this out in the COVID-19 era. So I'll take you through the background, the objective and the methods, results, and then we'll talk about the conclusion and the recommendations. So provision of multi-month dispensing, which is provision of ARTs at least for several months, has been shown to have several challenges. So there have been issues of drug stockouts where facilities do not have enough supplies to provide patients with longer ARTs. There's been issues with adherence to the eligibility criteria, because this was commonly provided as a DSD, so a differentiated service delivery, to a group of patients. So there was an eligibility criteria that needed to be followed, and so some healthcare providers were not conversant with that. Also, there have been issues with pill burden, whereby patients are not comfortable to carry a lot of bottles of pills because they feel like it leads to disclosure of their status. So, and lastly, commonly we've had issues of the patients needing frequent consultations, and so they didn't want to be giving long supplies of ARTs for longer months. However, there have been some studies which have shown that there is reduced workload of staff, so healthcare staff have embraced it, and also improved retention in care. Some studies have shown that patients are less likely to be late for appointments and not to be lost to follow-up. In Malawi, prior to COVID-19, 6-monthly multi-month dispensing was administered as a DSD, so differentiated care. It was only for stable patients. You had to be adherent, and there was an eligibility criteria. After COVID-19, in order to decongest the clinics, the government rolled out a policy where they relaxed the criteria for 6-monthly dispensing and allowed for other people for less than 18 years of age, and also those that did not require viral load results in order to be switched to 6 months. And I'll just walk you through the changes in the criteria before and after COVID-19. So you see, before COVID-19, you had to be on treatment for at least 6 months. This was changed to 3 months. Before COVID-19, you had to be on treatment at least on the current regimen for 3 months, and they changed it to 1 month. And interestingly, and most importantly, you also had to be at least 24 years of age before COVID-19, but after COVID-19, you could be from anybody from 20 kgs, so including children. And then you also had to have a viral load suppression, which was low at the lowest level of detection before COVID-19. But after COVID-19, they were allowing for adherence problem was not a contraindication, and also viral load suppression was not a requirement. And also for pregnant and breastfeeding women, they allowed them to get 3-monthly refills. So we set up to see the feasibility and the acceptability of this new criteria in Malawi, and especially to look at the barriers and facilitators influencing this feasibility and acceptability. And we used the CFR model, so we were looking at basically what are the barriers and facilitators, thinking about it in terms of the inner settings, so in the hospital, outer settings, outside the hospital, as well as the individual characteristics, so the healthcare providers that are rolling out this. And also, we were also interested to look at effectiveness. So in our study, we considered effectiveness to say, did this policy actually work in real life setting? And we thought we could demonstrate that by looking at whether there was the proportion of people who got the 6-monthly refills actually increased. We also were interested to look at retention in care during the 2 time periods. So it was a mixed method study. This study took place in 2 primary healthcare facilities. One was an high volume urban facility, and one was a peri-urban facility in 2022. We had 2 time periods, which was based on when the policy was rolled out. So the policy was rolled out in April 2020, and so we wanted to look at the period. We allowed for 3 months as a buffer period, and so we wanted to look at the period from September 2020 to March 2021 as post the intervention, and we looked at a similar period before that, starting from 2019. And then we had two tiers of study population. So we looked at the healthcare workers. We administered survey questionnaires to them, so a structured questionnaire, and also we had in-depth interviews with them. And also we looked at the patient data, which we accessed through the electronic medical records. And this patient data, for this evaluation, preventing findings for those patients that were more than 18 years of age. And this was because it was easier to determine how they had switched, because the doses are standard, compared to when you're looking at children where the doses vary. So the patient data will be for those more than 18 years of age. Okay, so we approached all healthcare workers above 18 years of age, and this was by pretty much convenience sampling. So everybody at the health facility who seemed interested in the study, we approached them, and if they consented, they got the survey questionnaire. So it was a self-administered electronic questionnaire. Afterwards, we did this was a purposive sampling now. We wanted representative from each cadre, because the healthcare workers were from various cadres, and so we wanted representation of each cadre. And then from these, we were able to administer the in-depth interviews. So our results, we managed to carry out 77 healthcare worker surveys, and majority of our population were females. Majority of our population were nurses and clinicians, but we also had several cadres like diagnostic assistants, we had counselors. Of note is that the rest of the information that I'll be presenting will be based on these 29 people, because when we are searching feasibility, acceptability, and also barriers and facilitators, we targeted this group because these are the ART providers. So if you see my next slides, they'll have a total of about 20. Our healthcare workers had a mean age of 34, and most of them had been working for about 6 years. When we conducted in-depth interviews for 10 of these, as I explained, that for feasibility and acceptability, we focused on the clinicians and the nurses. And so you see that majority of the IDIs, which were 10, we had mostly females, and they were mostly clinicians, about 33 years of age, and had worked also roughly the same time, about 6 to 10 years. For the patient level data, so we accessed data, as I said, from 2 time points. So from 2019 to 2020, we had 5,689 patients. And from 2020 to 2021, we had 5,054 patients. Now, I want to emphasize that the patients, the numbers are differing, because we only looked at the ones that came during the time period. Some of them are the same people, but some of them are not. So we focused on who came during this time period, and we abstracted their data. Our patients, you see the mean age is around 39, and then post, it was 40, just a year older. Most of them were females, and the distribution is the same, pre and post. You see that most of them have been pre, they were on ART for 5 years, and post, it was for 6 years, for just an additional year. And just to note that pre, most of them were 74% on DDG-based regimen, while as post, you see most of them were on 98% of them were on DDG. And just because this policy was happening concurrently with the DDG rollout, expanding the DDG rollout. So when we talk about feasibility, we can say that 90% of the staff thought that it was quite feasible. They thought it was simple. They adapted it from doing 3 monthly refills. And with, of course, them noting that they had challenges because of drug stock out. In terms of acceptability, most healthcare workers thought it was quite acceptable because it prevented themselves from COVID-19, and also they thought it reduced their workload because they were seeing less patients per day. When looking at the barriers, the most reported barriers was the lack of drugs, so antiretroviral drugs, and also cotrimoxazole. So this was the major barrier, because even if they had enough antiretroviral drugs, they still needed and less cotrimoxazole. Patients ended coming up frequently. So that was the major barrier, as well as the other barrier was the fear of COVID-19 vaccination, which led to patients not coming to the clinic. In the inner setting, it was access to viral load results. Even though the criteria allowed for you to transition somebody without viral load results, it turns out our clinicians and nurses still relied on it, and hence they reported it as a barrier, because if it was not available, they were not able to transition the patient. Another last barrier was that towards the beginning of the policy, because there was no formal training, they decided that they had inadequate knowledge of the policy, which led to them also ending up putting ineligible people on the 6-month refills. And this is just an extract that I took of a healthcare worker who reported that, there was a rumor that you first get the COVID jab before receiving drugs. And so people were afraid to come to the health facilities. And if people are not coming to the health facilities, they could not transition them. The facilitators, the interesting one for me was the drug packaging. And so one healthcare worker noted that the minute we started receiving drugs in 3 months, supplied in bottles, which had 3 months supply, that worked well for us because the patient was getting 2 bottles, whereas previously we had drugs for 1 month supply, and then the patient would get 6 bottles. So they thought that was an interesting facilitators. Other facilitators for the inner setting included review meetings, facility orientation, teamwork together, and also very important for us in Malawi, the electronic medical record system, because we come from a paper-based background, but recently we're using the electronic medical record system, and this was used to easily track who received ART and the dispensing. Individual characteristics, I think that motivated them. Fear of COVID-19 acquisition, so healthcare workers were motivated to transition patients because they're afraid of COVID-19. Prior experience of them doing the 6-month refills in stable patients, not as a DST also was noted to be a facilitator, as well as they had a good perceived behavior capability because they rated themselves as being competent when they had to rate themselves on a Likert scale. And then looking at effectiveness, so we were able to see a 20% increase of those that were provided 6-monthly multi-month dispensing pre and post, so from 67% to 87%. Retention to care, we had a 3 percentage point increase. At that in post, it was 99%, and pre, it was 96%. But I would like to emphasize that for the retention to care, this is preliminary data. We are still trying to break this down carefully. However, I will conclude. So in our study, we believe that administering the 6-monthly multi-month dispensing is feasible and it's quite acceptable, even using the relaxed criteria, as long as you have a supply of ART. So our results show that it's feasible, and I think this is a policy that could be made standard. However, so a disclaimer, we believe that as you're transitioning more people to 6-month dispensing, it's quite important to monitor the viral suppression as well as their retention into care. And those are my references, and obrigado. Thank you so much.